Hello, I'm Dr. Obey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old. To grow old in good health. Welcome to our show. Well, we're here again, and I would like to emphasize caring and sharing. Remember, care about yourself and go to see your doctor such that you can do better as far as your health is concerned, that longevity, having your mental faculties, all that comes together when you take your medicine appropriate. You go to regular appointments to your doctors and make sure that you're healthy. And that's what caring about is, caring about yourself. And then once you do that, share your good knowledge of medicine with others so that they will go to their doctors and check out what's wrong with them so that they can have long lives as well. All right, guys, remember social media, okay? OBeyyourdoctor.com. Alrighty, go to that website. There's so much medical information. All you have to do is go there, read. You can even contact me. Listen, Facebook, Obey Your Doctor, and Twitter, as well as Instagram, Obey Your Doctor. Come on and check us out. Facebook family, come on, check us out. We're doing great things on Facebook at this particular time. All right, let's talk. I want to talk about blood thinners today in our Let's Talk segment. And blood thinners, let me tell you, millions of people out there are on blood thinners for many reasons. But there are four major reasons I would like to talk about today. The first is it's called atrial fibrillation. And atrial fibrillation can cause strokes. And let me explain just for a minute. Atrial fibrillation is an abnormal or irregular rhythm of the heart. And because of that irregular rhythm, there are blood clots that forms either on the heart valves or in the chambers of the heart. A little piece of that blood clot will flick off and it will travel up the arteries into the brain. And right there, it causes a stroke, just like that. We use blood thinners to prevent those blood clots from forming. Understand that atrial fibrillation can cause strokes if you don't use an appropriate blood thinner. The second one is called DVT, and that is where you have, and that's let me explain that. That's deep vein thrombosis, and what that means is that there's a blood clot that forms usually it's in the legs or the pelvis region, and a little piece of clot comes off, and that one travels up the veins, and it comes into the right side of the heart, and then it will go into the lungs and gets wedged into vessels of the lungs so that the lung is not getting an appropriate amount of blood. That way you become very, very short of breath. Understand that DVT, deep vein thrombosis, and pulmonary embolus is when that blood clot lodges in the lung system. That it's an enormous amount as far as number is concerned per year. There are more pulmonary embolus or blood clots in the lung than breast cancer, traffic accidents, and HIV. If you combine all three of those together, it won't amount to as many blood clots that we have per year in the United States. So using blood thinners, it decreases the blood clots in the leg and prevents pulmonary embolus, and it decreases the blood clots that can form in the heart, producing strokes. Very important. Blood thinners, but talk to your doctor about that. All right, guys. We got a great show today. Our main topic, and I am just so happy that the physician has been able to come in and do a second show for us on this particular topic. The topic is, I have cancer. What do I do now? And Dr. Kevin Clark has come here, and he's going to do a second show for us. Dr. Clark is a surgical oncologist, and this topic is just so important for so many people out there that may develop cancer or who've had cancer or who have family members that have cancer. I have cancer. What do I do now? Dr. Kevin Clark, welcome to our show.
Thanks for having me again.
All right, all right. Now, we covered this last time, and I'll get this stethoscope right here. I always have a problem with it. We covered this last time, and we talked about many aspects of this, about when somebody realizes that they have cancer, the doctor telling him about that, him or her about that, what can be done. But I want to take it to another level this time. What I'd like to talk about is, and if we have a chance, we'll revisit some of the things that we talked about the first show. But this time, I would like to talk about the spiritual needs as far as support for these patients. Do you find that the clergy is a major factor when somebody is given this particular diagnosis?
Absolutely. I think, as we mentioned before, once you hear cancer, it automatically puts you in a state of shock. And support is enormously important. Not everybody is religious, so
Right.
I would say if you are religious, certainly the clergy, whatever spiritual person is of importance, I would say. So if you're Catholic or if you're Protestant, if you're Jewish, if you're Muslim, whatever that particular person is that's key is very important. But certainly, if you're not religious, any family member or key person that is can give you support is going to be very important because the diagnosis is very hard, and not everybody can take it. And you shouldn't go through it by yourself.
Right, right. Now, I remember we said last time that if once you are going to the doctor, I know you've probably gone to the doctor and you've gotten tests and you're going back to get the results of the test. You shouldn't go by yourself. That's important. We have mentioned that in the past.
Right. And that's, as soon as you hear cancer, again, you forget everything.
Right.
All the questions that you should be asking, all the things that you should be concerned about, because you're in that state, you can't do it. But if you bring somebody else with you, they can kind of buffer that and support you in that sense. And they'll ask the questions that you should be asking, and kind of nudge you along and say, well, yeah, you should be asking this, and kind of remind you of what's going on.
Right, right. I understand. What about, okay, and I know we had talked about a little bit about surgery, and tell me about, there was something I wanted to cover as far as post-surgery. Now, and you're a surgeon, so but we're going to get into this further. But post-surgery with cancer, is it a longer recovery time usually?
It depends on the cancer. It depends on the operation. So certainly, if you in the stage of the cancer also. So some patients present with more advanced disease, and their body's in a little bit more debilitated fashion. So they're not quite, the nutritional status is not quite as up to par. They're weak. And if you do a big operation on those patients, it's going to take a lot longer for them to recover. If you're pretty healthy up front and you have no other comorbid conditions, hypertension or diabetes, and it's a relatively small operation, then those patients tend to recover faster. So there's a lot of factors that go into how quickly you recover based on what the cancer is, your state going into surgery, and what exactly has to be done as far as surgery.
Okay. What about weight and weight loss and things like that? Is that an important factor? Should patients be, prior to going into surgery, should they be taking, supplements and things like that to build themselves up to make sure that they're nutritionally sound?
So, yes and no.
Okay.
So
I thought that was going to be a yes.
well, certainly you want to go into it with good nutrition and good health, if you can. Part of the problem is once you have cancer, because the cancer tends to put you in a debilitated state, it's hard for you to actually build up once the cancer is there. So certainly, if you can, you should have nutritional supplements. but a lot of times it's not feasible because the cancer itself, it causes what we call a catabolic state. So it actually breaks the body down.
Oh, okay. Let's talk about, and I'm moving along because there's so much we had. Last time we ran out of time, and I really want to get a lot of these questions out of the way. Advanced directives.
Yes.
And we're talking about living wills. How important is this?
Very important.
Okay.
Very important. I think up front, you have to have an idea of what it is you want and what it is that you don't want.
Okay,
And
you mean as far as if something happens to me, meaning if my heart stops, do I want you to jump on my chest and pump my chest, or do I want to be on the machine to breathe for myself?
Right.
That's what you're talking about?
Right.
Okay, all right.
And it's so there are things that we can predict and things that we can't predict. Certainly, things can happen during the course of treatment, whether it be surgery, chemotherapy, or just being in a hospital.
Right.
That sometimes we can't predict. And it's good to know up front what patients' desires are, because then we can figure out what it is. Should we proceed in this particular fashion, or shouldn't we proceed in this fashion?
Right.
And it's also good for the family members because it takes the pressure off them. So they don't have to make those decisions if they're already made up front. So.
I understand. And I just want to let you know that, and this is as a side, we did do a show on that one, and it was an excellent show with a judge that actually came in and talked about advanced directives. All righty. So we will put that up on Facebook for you, just to let you, because it's such an important topic. Palliative care and hospice care. Touch those for me, because I know they come in, you're associated with
those,
that.
and for the medical community, and actually for patients, it's kind of I won't say taboo word, but it gives the notion, and it's not really the correct notion, of giving up or of not treating.
Let's explain what we're talking about, because we threw the words out there, but there are some people that may not know what a palliative care is. Like it's supporting the patient, and if they're having pain and stuff. I'll let you explain it in hospice care. Just tell them exactly, just a minute, what it is.
It's supportive care, and it's really care that's designed to relieve symptoms and pain. So when we consider palliative care, there are a couple things that we think about. So if pain is a main symptom, we can do things to relieve the pain. If patients are bleeding, we can do things to stop the bleeding. If patients are obstructed, we can do things to relieve the obstruction. Now, palliative care as a concept, it still involves therapy. So it doesn't mean you're not doing anything.
Right.
And sometimes palliative care involves surgery. Sometimes it involves chemotherapy. And active treatment. Now, hospice is still palliative care, but it's not active treatment in the sense that we're not treating the cancer. And it's designed for patients really who are at the end. So they're terminal. Their cancer is not treatable in the sense that effective therapies have stopped working. So surgery, chemotherapy, radiation have stopped working, and it's really designed to make them comfortable. And that's usually, we make that decision in conjunction with all the medical staff that's participating in the care. So one person doesn't make the decision. It's made in conjunction, and looking at the overall goal and where the patient is in their overall care. All right.
I understand that you said we make that decision, but let's clarify that. We come to a conclusion to present it to the family, or take out the living will and find out what the patient wants. We as physicians don't make the decision to do that. Would be a family or a decision that's made prior to with a living will. And all right, excellent. All right, this is what I want you to do for me. I want you to take me through prepping for surgery. You know, how does a patient come into the OR? What happens when they get there? What happens when they come into the OR room? What's the team like? Tell me all this stuff. I don't know the good juicy stuff. Tell me what's going on.
All right, so let's start from the office visit. So the office visit is designed, once you have the diagnosis, you sit down, you discuss what the cancer is, what the stage is, and what the treatment is. So if the treatment involves surgery, we go over that in detail, what exact details of the operation, all the complications, everything in that setting. And all the questions are answered at that point. Then we get a date for surgery. And usually that date, it could be, depending on what the surgery is, a week or two from that point. the day before surgery, this is where everything starts. So the nurse calls you around 5 o'clock, reminds you of all the things that you should or shouldn't be doing in anticipation of the next day. So nothing to eat or drink after midnight.
Okay.
Is probably the most important thing. And to take your medications the morning of with a little bit of water.
Okay.
So we don't want patients not to take their medications.
Okay.
Take your medications in the morning that you normally take.
All right.
Then once you come into what we call the holding area or the preoperative area.
Right.
And there you will meet with the nursing staff, and they'll go through a history and physical examination again. And they'll ask you, depending on what the operation is, and they'll ask you 10 times. If it's on the right side, everybody will ask you right, because again, we want to make sure we operate on the right side.
Yeah.
You'll meet the surgeon that morning. You'll meet the anesthesiologist. Now, the anesthesiologist is a doctor who puts you to sleep.
Okay.
So surgery can't be done without the anesthesiologist.
Okay.
So that's really the team. It's a nurse, the surgeon, and the anesthesiologist really comprise the core of the team.
Right.
So after you come in the holding area, now we're going to move to the operating room.
Okay.
So now you get wheeled in, and the operating room is a completely separate area in the hospital. It's walled, it's contained, it's walled off because everything has to be sterile.
Right.
So
No bacteria. We
bacteria.
are clean here.
And
All right.
only specific people can walk in. So you
Right.
can't have random, even physicians just walking into the operating room. Only specific personnel come there. So you get wheeled in, and it's usually very bright. And there's a lot of instruments, a lot of machines around when you get in. Again, the nurse is going to introduce himself or herself to you.
Right.
And you'll see the anesthesiologist again. And then the surgical team, which typically comprises of the surgeon and an assistant.
Okay.
And then you get moved on to the table. Now, the table is always small. It's a small, narrow table.
Okay.
And it used to be cold, but now we have a little heating pad underneath
Oh,
to make you comfortable.
All right.
And the anesthesiologist will talk to you to get you comfortable. And typically, they'll give you what we call a cocktail. And that's a fancy word for drugs or medications to make you sleepy.
Oh, all right. All right.
And then once you get sleepy, they'll put the tube in. And then, depending on the operation, we'll clean you up, and then we'll get to work.
Now, when you say put the tube in, you mean
a breathing tube.
The breathing tube
Right,
in.
put a breathing tube.
So, all right. So the anesthesiologist actually gives you some medicine to put you to sleep.
Right.
And once you're asleep, real quick, he puts the breathing tube down. And then he puts you on the machine, and the machine actually breathes for you. You are actually almost paralyzed to a certain degree, so that you're not moving around on the table.
Exactly.
So it's very interesting because you are in his hands at that particular point. All your breathing, your heart rate, your pulse, your everything that's happening, all your vital signs, all the important stuff is controlled by him, the anesthesiologist.
Yes.
He's a very important guy in this in this group of people. And then you go on with the surgery, depending on what type of surgery we're talking about. All righty. It's so interesting. Boy. Now let's step back for a minute. What if patients come, and before the surgery, you've seen them in the office, and they may have other diseases that like a heart problem or a kidney problem. What do they have to do to get actually cleared for you to feel comfortable taking them to surgery?
So one of the things that we have to make sure is that it's safe to put you to sleep and it's safe to do the operation.
Right.
And that involves making sure that if you do have comorbidities, that they're under control. So if
comorbidities. You're hitting me with these big words here. Went right over my head.
So comorbidities means other medical problems like high blood pressure, diabetes, if you have COPD or asthma, those things have to be what we call controlled or optimized. So we're not going to get rid of it completely, but it has to be optimized.
Right. You have to be in a good, stable setting as far as those diseases are concerned. Your blood pressure has to be under control. Your blood sugar has to be in a good level. Right. You can't be wheezing, going on the breathing machine. Those type of things.
Right. Because all those things affect our ability to not only do the operation, but to get you through successfully.
Right.
So we want to make sure that all those conditions are are optimized.
All right then. What about, I understand, and I heard talk about robotic surgery. Just for a second, what is robotic surgery now?
So robotic surgery is one of the advances that we've had, and it's been around probably, I'm probably going to get this wrong, but probably at least 15 years now, I think. And it involves, you're still operating. So the misconception, the robot's not operating. You're operating but using robotic arms to do the surgery.
Right.
So rather than sitting next to the patient at the table, you're sitting at a console and you're controlling the robotic arms that are sitting next to you.
Right.
So it's remote surgery essentially, but you're still physically in the operating room.
Right.
It's minimal invasive surgery in the sense that we're not making a big incision to do the operation. It's the same operation as if we did it open, but with small incisions and using the robotic arms to do it.
And recovery time, I understand, is really cut down dramatically.
Right. For some procedures, patients go home the same day sometimes.
Wow.
So, yeah.
Interesting, interesting. What I'd like to do, there are three, and if we have the time to get to all three of them, there are three diseases or types of cancer, I should say, that I'd like to cover. Number one being breast cancer.
Okay.
All right. Just give me some idea. What happens once you diagnose the cancer? What's next for these patients?
So once we make the diagnosis, we stage it. And staging means we find out how extensive it is.
Okay.
And based on the extent, the treatment's going to differ. So either you're going to go to surgery, you're going to get chemotherapy, and that all depends on the stage. So we discussed that at the time of diagnosis.
Okay.
So once we make that determination, again, surgery, there are two things as far as surgery. One is called a lumpectomy, where we just take the lump out, which is taking the cancer out with some normal tissue.
Okay.
Along with radiation.
Okay.
And the other option is a mastectomy, where we take the entire breast off.
Okay.
Now, there are reasons to do one versus the other, and we usually discuss those things in detail at that time, along with reconstruction if you're going to get a mastectomy. So at the initial visit, we discuss all of those things that pertain to surgery. Now, if a patient has for instance, stage 3 breast cancer, they typically get chemotherapy first.
Stage 3, now you're over my head a little bit.
So when we stage in cancers, staging means extent. So how bad the cancer is.
Or how far it's spread, or if it's
spread.
gone to other places, other parts of the body.
Right.
Okay.
So it usually goes from stage 1, 2, 3, and 4. So stage 1 means it's localized, and stage 4 means it's in separate parts of the body.
Right.
And then stage 2 and 3 are somewhere in between. So stage 2 means it's somewhat localized but spread a little bit to the lymph nodes, and stage 3 means it's probably gone to the lymph nodes, roughly speaking.
Right.
So stage 3 patients would be the ones that you would send for chemotherapy first. So they'd see the medical oncologist to have that discussion. But again, like we spoke about before, cancer care really is coordinated. So we don't make any decisions in a vacuum. So we all discuss the patients to make sure that we're all on the same page. So if a patient is going to get chemotherapy, we make sure it's appropriate to get it after surgery and not before surgery. Before we proceed with treatment.
Tell me about, we were just talking about chemotherapy, tell me about the ports. How, I know that chemotherapy is a rough, it's rough on our veins. It really does beat the veins up. So you after chemo, a couple doses of chemotherapy, you don't have any left. Tell me about these ports that they put in for medications, chemotherapy. I think they're called porticats.
Right. Yeah. So the porticat, it's a catheter that actually sits. It goes into one of the big veins, either in the shoulder or the neck, and it really is designed to facilitate treatment. So as you mentioned before, given chemotherapy drugs through the peripheral veins. Every time you come in, you'll have to get a stick. And those drugs can cause those veins to what we call sclerose. So over time, you'll have less and less veins.
They become non-functional, basically, after the chemotherapy,
So this is a procedure really designed to facilitate therapy. It's a port that sits in the shoulder and the neck, and it can be accessed easily. So you don't have to get stuck necessarily in the vein every time. You just put it in a port, each time you get treatment.
Okay, so it's an access vessel that, that allows you to give the chemotherapy, and the patient is much more comfortable.
Right.
All right then, all righty. There's so many questions. Breast cancer, is there, I'm going to move it along because we have about 3 minutes. Breast cancer, is there any genes associated with breast cancer now?
So yes, so there's the two main ones that we test for are BRCA, so BRCA 1 and 2. And they're, as far as hereditary breast cancer, they're the two most common ones.
Right.
And there are specific things that we look for. So if patients are less than 50 and they have what we call triple negative breast cancer, then we test for it. If they have a strong family history, then we test for it. If they have, certainly males who have breast cancer, because that's so unusual, we test for it.
Right.
So those are the two main genes that we test for in breast cancer.
Okay.
There are other ones, but not as prominent.
And if you have that positive genes, then you think about your daughters or, you know, people like that, they should be tested as well?
You think about everybody in the family, actually, because it's not only breast cancer. So these genes actually confer a risk for ovarian cancer, pancreatic cancer, prostate cancer. So we think, when we measure them, we always just think of breast cancer, but it actually has implications for other cancers. So if there's a BRCA gene in the family, the males also potentially can be affected.
Oh man, all righty. Pancreatic cancer, that's gotten a lot of media lately. Tell me a little bit about pancreatic cancer.
So unfortunately, we haven't made a lot of progress in the last couple of years, at least surgically. I think some of the chemotherapy drugs, we've made a little bit of progress. It's a terrible cancer to get. Most cases, patients don't live. We typically look at the 5-year survival, and it hasn't changed appreciable for the last 10 to 15 years, or even 20 years.
Right.
The diagnosis, again, most patients can't even get surgery once they get diagnosed because they get diagnosed so late.
So late, huh?
They have abdominal pain. They get what we call jaundice. So if you turn yellow unexpectedly, that's a bad sign. If you have back pain, if you're diagnosed with diabetes at a late age and you're not obese, that's one of the signs.
You know, we're gonna and I trust we could get into that more. We're gonna have to get you back again to talk about some of the other aspects of this, because there were other topics that we didn't get. We're run out of time. Dr. Clark, thank you very much for coming in. You're a gem, and you're a wealth of knowledge, believe me. Thank you very much. All righty, guys. In closing, remember, caring and sharing. Share your medical knowledge and care about yourself. We can do this together. We can all be healthier. All righty? Never institute any change in your medical care until you consult your physician. I trust each and every one of you continued good health. I'm Dr. Obey, and this is A Moment in Medicine. Until next time, peace to you all. Thank you. So it was such a great time. But next time we're going to have to truly talk about the colon, and we'll have to talk about more about the pancreas.
We just, we get a pancreas.